me?
Yes, please go ahead.
Okay. Sorry. Technology today, I think my connectivity is very bad today. As I was saying, a very warm welcome to everyone. Hello.
We're here. We can hear you.
Okay. Yeah. Let me quickly, because I think now we're running out of time. I'd like to welcome everyone.
Yes, 500,000 this year. How can that be? I wonder if the board sits there and considers
Warm welcome to everyone. Can you hear me? I'm getting some feedback.
Yes, we can hear you.
Are you able to hear me? Oh, okay. Yes, as I was saying, my sincere apologies, but a warm welcome to everyone to this webinar where we'll be looking at the introduction of the COVID-19 vaccine with lessons from Malawi. This has been the third in the series where we heard from other countries. My name is Catherine Muyawala, and I'm the BLN Network Coordinator. And we're having these, webinars so that we can all learn from one another. So for most of us, we know that, I definitely won't even go into the normal nitty-gritties of the webinar housekeeping. Just a quick one, just to ask everybody to make sure that they're muted and that the videos are disabled, and so that we can allow the discussants to speak without interruption. I just let everyone know that there'll be a question and answer session after the discussion. And we're going to ask you to submit any burning questions into the chat box, and they'll be logged and answered during the question and answer session. And of course, just to let you know that this webinar will be recorded, and that the link to the recording will be shared via our Google groups and also through the BLN website. So, as I have already said, we know that the COVID has really affected us in so many ways, and we know that currently we have over 180 million cases. That's according to WHO, and we've had close to 4 million deaths. This is around the world. And then in Africa, we know that our cases are above 5.3 million, and we've experienced quite some devastating numbers in terms of death. And we're very grateful to WHO, UNICEF, Gavi, the Vaccine Alliance, and all the other partners that have worked diligently to ensure that the world receives this much needed vaccine. It receives the much needed vaccine. And so in that case, would like to learn more from the countries that have been deploying the vaccine. We know that currently about 2.4 billion vaccines have actually been deployed globally. And in Africa, we've got a number of countries that are more than 47 that have benefited from the COVAX facility. And that's why we're having these learning webinars, so that we can, because we're all on the learning curve. And, I'd like to believe that everybody wants to learn. And we've had other countries come on board. In the last two webinars, we heard from Cameroon, and we also heard from Liberia how they've been doing with the COVID vaccine deployment. So today we'll get to hear from we get to hear from Malawi, and we're very happy that we have in our midst Mr. Mangumba, Mr. Mangumba from Malawi, who's going to speak to us about that. Sorry. And just to lead us through the discussions for today, sorry, we have Dr. Osha Manangazira, who happens to be the BLN peer advisor from Zimbabwe, and she is a public health expert who has worked as a lead epidemiologist for the Ministry of Health and Childcare in Zimbabwe. And for the last 15 years, she spent in an extensive experience in the coordination and management of communicable diseases, prevention and control programs. And her responsibilities and experience span the control of communicable and non-communicable diseases, health promotion, implementation, science, and health information. She is responsible for planning, coordination, and management of public health programs, as well as the development and implementation, monitoring and evaluation of health information, disease prevention and control, including emergency preparedness and response. Here, looking at policy strategies for national, regional levels, and during her distinguished career, she also received international recognition. Dr. Manangazira has introduced several national programs and made significant contributions to science through research and has published numerous articles. Additionally, she has led and coordinated various national population-based communicable disease surveys, notably the Zimbabwe Demographic and Health Survey for the years 2005 to 2006, and also for 2010 to 2011, as well as 2015 to 2016, and has also led the coverage surveys on measles, human papillomavirus, which is known as HPV, the rotavirus, and general EPI surveys, among others. She holds a medical degree in medicine and surgery, an MBA, this is general business administration, and a master's in public health. So a warm welcome to you once again, Dr. Manangazira, and it's good to have you moderating the discussion for today. I will now hand over the floor to you to introduce our distinguished speaker, Mr. Dennis Mangumba, and just lead us through the discussion. Dr. Manangazira. Dr. Manangazira.
Hello.
Hey, Dr. Manangazira, the floor is yours.
Okay. So thank you so much. My apologies if I got a bit disconnected, but I'm back online again.
All right.
Thank you for the introduction. Hello.
Yes, we can hear you, Doc.
Okay, so thank you so much for the introduction, and thank you for organizing this very important webinar. Also appreciating the previous two. My job is easy. I'm just going to be moderating this discussion. So I see the agenda is already up. And I would perhaps quickly move to introduce my colleague and brother, who is going to be doing the speaking and sharing experiences from Malawi vis-a-vis the COVID-19 vaccines. And this is Dennis Mangumba. He is a real veteran in terms of the immunization programming, having worked more than 28 years at all levels, the district, regional, and national level in Malawi. he has participated in all new vaccine introductions in Malawi since 2002 and has been involved in the planning, organizing, implementation of both routine as well as the supplementary immunization activities in his country. Currently, he is the EPI data manager, responsible for designing and implementation of the M&E activities for the program, but also assisting the EPI manager in terms of preparation of quarterly annual reports on program progress, among other activities. Janice is a holder of an international master's in public health on global health, and he also holds a certificate in monitoring and evaluation. And currently, he continues to progress academically. He's studying for a project management in global health with the University of Washington. So, ladies and gentlemen, colleagues and friends, that's Dennis Mangumba, and he is going to be sharing his experiences with us from his country, Malawi. Thank you. Over to you, Dennis.
Yes, good evening. As already said by the moderator, I'm Dennis Mangumba from API program in Malawi, and I'll be able to share with our experience during the introduction and implementation of the new COVID vaccine in the country. Thank you, moderator.
Are you there?
Yes, I'm there. So I thought you had a small prepared presentation. I think we'll just move to the discussion and ask him in terms of how Malawi has arrived at the decision to introduce the COVID-19 vaccines.
Thank you, moderator. I think as a country, it was not an easy thing to come up with a decision to start the COVID vaccine. As you are aware, the moderator, our country, I think, was the last country to report positive COVID cases, and that was on 1st April 2020. After the introduction, after the confirmation of the cases, then the country started skyrocketing on number of confirmed cases of COVID. So look at that epidemiological data. It's one of the things I think we consider that I think the country need to start giving the vaccine. And this was also came together with the opportunity coming from Gavi on the open win for COVAX, where they said Malawi are going to be supplied with the vaccine. Then we say, okay, this can be another opportunity. Then we engaged our mind tank to look at pros and cons of the introduction of the COVID vaccine, so that to do the literature review, then gave the recommendation. We said that no, Malawi as a country, we need to go ahead and introduce the vaccine like the AstraZeneca, because they looked also at the capacity, content capacity of the country. So listen, I think the most important vaccine which we can use now with our content capacity. Let us take the AstraZeneca vaccine, because it can be kept at +2 to +8, other than Pfizer or Moderna, which were available at that time when we were making a decision. This is how the country came up with the decision of the vaccine. Thank you, moderator.
Thank you very much. And the follow-up question will be, what were the challenges that you encountered in terms of the introduction of the COVID-19 vaccine? I know you already mentioned the selection process and decision making in terms of which vaccine to use, but were there any challenges encountered? And maybe we would want you to touch on, in terms of the preparedness, the vaccine delivery. You did mention the cold chain, but we also want to know a bit more in terms of the
logistical
of it, among other sectors, other challenges.
Okay. Thank you, moderator. I think as a country, we had several challenges during the introduction and implementation of the COVID vaccine. If I can start with the preparedness, yes, I think we had also some challenges with preparatory time for the vaccine. One of the challenges was we didn't have adequate time for that because we are supposed to let the national vaccine deployment plan, submit it to be approved, and then the vaccine will come in. So it was given within a short time, but I just would not be able to finish to get the vaccine before completion of the national vaccine deployment plan. Then also the other one was we didn't have adequate information on the disease itself and what the vaccine, what type of vaccine we're going to get, and what type of disease we're going to do. So there are a lot of issues surrounding the knowledge on the vaccine as well as the disease of the COVID-19. So those also create affect our prepared activities. Then also we had all competing priorities. The vaccine, people had already struggled with to control the epidemic of COVID. So we had those competing priorities. Because we had the vaccine the other side and we have a disease which was also a lot of lives. So for us to say, okay, let's shift the attention. Let's shift the attention to vaccine. It also was a challenge. Then also we had a challenge of the best time of when we not move around, not hold meeting because of those physical meetings were done. Then travel not be what is done because of the government. So this affected also our preparatory activities especially the COVID-19. Then for the green biology and cold chain, on the cold chain, mainly the first step of cold chain is okay, and the problem was on the distribution part of it because most of the time what we do is when you have a new vaccine, we get the vaccine.
Hello. Hi, Dennis. Hello, Dennis.
Hello.
Sorry, can others mute their microphone so that we can hear Dennis properly? Just find your microphone and then mute it. So, yeah, thank you. You just continue.
Thank you, Dianes. I was talking about our challenges during the introduction of the COVID vaccine. Then what we had was on the river logistics and cold chain issues. Mainly on a cold chain, river and logistics, we had the problem with how to distribute our vaccine to our facilities because we got our vaccine within a short time. We started to introduce the vaccine. So most of the time, what we do is when we get the vaccine, we distribute the vaccine to our regional offices and regional offices distribute to districts. But this time, because of short time which we had, the vaccine was taken from the national level down to the districts. So we are bypassing our regions because of time. So we didn't want to take a long time to get the vaccine to districts. Then also we had the challenge of the lifespan of the vaccine we were getting. You know, as Malawi got 360 doses from the COVAX facility. Then we also had the 102,000 doses from African Union, and also we had a donation from Indian government. So with the vaccine from the African Union, the last part for us when the country was ordered for 2 weeks. So this was a short period for us to consume all the vaccine within a short time. So that was also another challenge of logistics. Then also, we always use our routine vaccine to manage the use of the VPM and fridge tags. But this time, I think the vaccine came with no VPM. So that's why just telling people to say, okay, can you keep the vaccine at +2 to +8? Otherwise, there was no management to say either this vaccine has been exposed to high temperature or to low temperature. So that was another big challenge for logistics, which we got. Then on financing, this was a very big for us, a big problem for us as Malawi. We didn't have adequate funding for the introduction of the vaccine. As you know, we got only the vaccine from COVAX facility. There was no operational cost. So at that time, we're in a fixed, but I think we were able to do the vaccine because of whatever activity we did ourselves, which will be, I think I'll be able to explain later. So also once, okay, even at the beginning we didn't have funding, we continued opening funds. Later on, we were able to get some funds, which we were at least given to us a bit rate after we have already introduced the vaccine. Then also the other challenge was we had our partners during the introduction, but they had their own interests, specific area we wanted to support. So it was very difficult to manage whatever to be done now. They said, no, we are not going to give you fund for this one. We wanted this fund to be used for this activity. So that was also the big challenge during that time. Then also we had some challenges on identifying our target population, because what we agreed during the first phase, so we're going to vaccinate those health workers, those with combat, those with the social workers, and also those who are above 60 years. So it was a very big challenge because we didn't do a micro plan, a proper micro plan to say, okay, this is the number of people who are going to vaccinate. So that's also, that was another big challenge we're having. And also to know that this client is really has got an underlying condition to be given a vaccine. And that is what we do. Because in our country, we don't have a smart system where we can document each client who has got an underlying condition like diabetes, hypertension, even HIV. Those are given within that kept to the patient's self. So we didn't have that information to be easy to know that this client has got this condition. So it was very difficult to come up with the actual figure for those with underlying conditions. Because even when we try to look at the NCD, they just give us a proportion. But when you go down to the lower level, it was very difficult to get that figures. Okay, about national, they're talking about 10%. So what is the proportion at the facility level? What is the proportion at district level? It's very difficult to come to that. Then on the vaccine hesitancy and misinformation, we also had a challenge because we were overpowered by the social media. There was a lot of rumor, a lot of misinformation, epidemic, and also people had not enough information on the actual vaccine and disease. So this also gave us a lot of problem to tackle with. Then on data capture and management and dissemination, vaccine implementation, as a country, yes, we had our register with vote, who distributed to capture this data according to a target we selected. And also we even went further to develop an electronic register, getting it from the module which the Austro investor made. So we adapted to our own country. But going along, as we are going along, we had also problem because in the e-register people could not enter data because of one, there was a poor network connectivity. Two, they had not enough tablets. Three, also people could forget to sync the data after data collection. So all those also contribute to our data capturing. However, we had enough registers, which we paper-based, which we used. We had printed the registers, also the monthly report books, which also sent notices to them to send us report on daily basis using the paper-based. So we are using two parallel systems, the paper-based as well as the electronic register. So these are some of the challenges we encountered as a country to the introduction of the COVID vaccine. Thank you.
Okay, thank you so much, Dennis. We really appreciate your sharing in depth the challenges. So what have been the strategies that Malawi has put in place to address the said challenges, Dennis?
I think we had a lot of strategies which we did to overcome some of these challenges. The first one, we continue engaging our partners for resource mobilization to say, can you be able, if possible, to support the program with the activity we have planned for. So we're also moving them. So, okay, if you have this interest on this area, can you also please add another fund for this activity? So that's what we do in the community. We're going with the partners to do that. Then also we had social mobilization, very active social mobilization. We could use the media, for example, the TV, the radios, where our people from EPR program, our partners, could go there and talk about the vaccine and the process of vaccine. And also we had our ministers and the task force members also were talking about the same language about the importance of getting the vaccine as well as doing the other preventive measures. So that one also was done by our politicians and others. Then we also had on a daily basis press briefing, which was done by the minister, also by the chair of the COVID task force, president task force, and also by even the president himself at times of coming in to talk about the importance of prevention measure for the COVID vaccine, including the COVID disease and including the vaccine. So we also had some radio and TV slots, which also we are trying to sensitize the community the importance of getting the vaccine. So it was done either using the TV or radios. Then we also were very also open to our partners to say, okay, if you need to support the other areas, you can come in while we can identify other partners to do the other activities. So we are very open to our partners to come with any help or support which they can give to the program to introduce the vaccine or to implement the vaccine. Then for the data, which we had a problem as well, as I already alluded to, when we look at first, we had a discrepancy of our data from paper-based and the electronic. So the paper-based was very higher than the electronic. So we asked the digital health team to go aloud and do the data entry, so the data should be matching. So that one was done, and I think they went to all the districts and updated our data. Then also we continued providing the National Task Force. We are meeting every Thursday, giving update on vaccination. So once we have vaccinated today, we're able to give the update to NTF on every Thursday. We have a NTF meeting every Thursday. So we're giving the update, any challenge could be discussed there, and the solution will come up. Could be decided and could be also be discussed and implemented after the meetings. So these are some of the strategies which we use to roll out our COVID vaccine in the country. Thank you, Jenna.
So thank you. You did mention two things that I think resonate with all of us in terms of the competing partner interest. I know you mentioned that you're working with them, but is there a specific mechanism that you are using to address particularly the competing interests, and especially when it arises during a pandemic, when time matters, but also resources do matter? And then for me, the other issue is for you to clarify. You did mention that you were at some point overpowered by social media. And we know WHO coined a new term, which was the infodemic. You did mention the press conferences, but is there any other way? Are you also making use of the social media to counter and to put correct information out there? Over back to you, Dennis.
Thank you, Bosha. Yes, I think what you have picked up is true. With our partners, our partner person with NTF. So any issue has been identified in the NTF meeting, National Task Force meeting, they are able to come in and say we're going to do 1, 2, 3, 4. So that's how we involved our partners to address some of the issues we identified. Because when we saw that at least they're supporting one activity more than the other, we would also discuss with them. So can we also do this activity to support whatever they've been doing? So that was done as well. Then also on social media, yes, as a kind of engaging social media, we had the press briefing, we have a press conference with them. The people were coming to ask the API program, the messages which they can deliver to the community. So I believe social media are some of the rumors and misinformation which we had in the country. Thank you.
So thank you. There's just two other questions in the chat area. How has Malawi managed the personal registration for the vaccination, and which electronic system are you using? You did mention that you are only on paper based, but also the electronic system. So the specific question is, which electronic system are you using? Thank you.
Okay, as I already said already, that we are using the e-vaccination registry, which we adopted from the also investor which is informed. So So that's the electoral system we're using. But for registration, for that time, I think we're not so much using the registration which we get from the National Bureau. But we intend to do that later on. We're going to have another concept of ANSYSA that we need to do the pre-registration, which are developed the module now, so that these people should be able to register in advance, and then we also scan and just update then we'll be able to update their vaccination status. So that's what we are doing. But at least the e-registration, e-vaccination registration, which we got from the also invested, that's what the digital health adapted, and we have been using that one.
So thank you. Still on the data issue, Dennis. Are the health facilities reporting the data? And I think further on, we also would want to know whether you are capturing the data from the private sector, if they are playing a role in the vaccination, as well as the public sector. Obviously, you measure more on the public, but with COVID, we saw a lot of private sector involvement. Is that being captured? And how is it being used for decision making in the two systems?
Okay. Thank you, Portia. I think, yes, as a country, what we did at first, we say, as I said, that we developed the monitoring tools, we had the registers, we had the tally books, we had even the reporting form, which we displayed to each and every facility. But our mode of vaccination was quite a mixed one. First of all, when we were targeting the health workers, we trained teams at district level who were going around all the health facilities. Because by that time, we did have adequate funds to train each and every health worker. So the data which we were recording were coming from the teams where we had somebody focused for capturing data using the tablet, even the registers. So that data was reported to us immediately. But when we got additional funding, we were able to train our health workers. So we included even health workers who are the vaccinator, as well as the data clerk who are capturing the data. So they could enter the data in the electronic registry, as well as enter the data in a paper register. So those data that have been reported to us, we get reported to each and every facility, whether it's a public health facility or a private health facility, as long as they involved in a treatment of COVID vaccine, they're reporting to us using either a tablet and even the register which is there at their facility. So,
okay, please go ahead.
So what I can say, okay, what we did was we assessed even our tools which are used for building the tablets. When there was a shortage, the digital health team managed to mobilize other additional tablets and give to those facilities which didn't have the tablets. So that one also assisted us to have all the tablets around the country to capture the data for COVID vaccine. Then also through the electronic register, we were able to create a web where we had to have a data dashboard, and that assisted quite a lot on looking at the data which we have, compared with the data which we capture through the paper-based, and also from the dashboard we had, we could make a decision, say, can we have this vaccine from this side, let's go to this facility, because also, based on that one, during our discussion with LTF, also could update each other where there's people are not vaccinating and why they're not vaccinating, they don't have the vaccine, so we bring the vaccine to those areas as well. So those data capturing systems which we use, the combination of the paper-based as well the electronic, assist us to make a decision to where to give the vaccine more or where to get to assist them with financial whatever. So that also assisted quite a lot to the introduction and implementation of the COVID vaccine in the country.
Thank you. That's quite a wealth of information there. So, looking at the implementation so far of the vaccination program, what are the lessons to share in terms of introduction and implementation of COVID-19 vaccination? I know you did mention the knowledge gap, because the world and all of us have had to learn very fast about the disease, as well about the vaccines that were quickly, rolled out. So in terms of going forward, and I know you have not achieved yet immunity, you continue to acquire more vaccine and continue vaccinating the nation. What are the lessons so far?
Moderator, I think as a country, we have worked a lot on the vaccine production, mainly for this COVID vaccine. One of the reasons which as a country have led is the political will. You know, as a country, when people the vaccine are coming, people are saying quite a lot. But our president and his vice president stood up and were the first people to be vaccinated. On the same day, the other one went to the north, one of the southern part of the country. And that's built trust in the community. So, okay, this vaccine is very safe, opposite to what I've been saying. The other thing, what we also learned as a country, that I think having a micro plan or developing a micro is quite important. We'll be able to know who should be vaccinated and who should be vaccinated. Without a micro plan, it's very difficult for us to get the true denominators to use when we're going to calculate our coverages. So micro plan is quite important before we introduce any vaccine. The other lessons we have read as a country also is building capacity of health workers before we introduce a vaccine. This is quite important because we observe that during the introduction of COVID vaccine, because first of all we're targeting the health worker, and most of the health workers were refusing to get the vaccine, so it's not safe, whatever. But after sensitizing them, we find most of the people that are able to get as a country up to 80% of our health workers with COVID vaccine now, as I'm talking. So this was after when people they go to the facility, they will sensitize them, talk to them, because people were saying quite a lot about against the vaccine, but then when they understood and started taking the vaccine. So we think training, sensitizing or training health workers before the vaccine is quite crucial in the implementation of the program, the implementation of the introduction of the vaccine. So the also other lesson we have learned is that before you introduce the vaccine, we should have adequate finances, so that all appropriate activities should be done before you start the activity. So for this one, I think financial availability and material resources is quite critical in the introduction of the new vaccine. Then also we need to have accurate information for, I think as I already said, from the micro planning. So how many people, who are these COVID people, who are the people with underlying conditions, because you can estimate at using the NS, the National Statistical Office estimates, but that can not be a true reflection of what's on the ground. So having a micro plan will give a true picture of the people we are targeting for. So I think these are some of the lessons as a country we have read to the introduction of the COVID vaccine. Thank you.
Thank you, Dennis. So there is two other questions in the chat box. The first one is, let me just open it again.
Yes.
So it is estimated that COVID supply should significantly increase in the second half of 2021. So the question is, how is Malawi preparing for this rapid scale up? And then the other question is, do you have any system for adverse events following immunization? The other one is appreciation. Thank you, Dennis, for the great information. What strategies have you used to create demand for the vaccine, especially in the rural areas, which may not have much knowledge or access to social media? And then the last question is asking, what criteria are you providing vaccination in all health facilities or just selected ones? If so, what is the criteria used to select those few? And then the people who subscribe to the COVID-19 vaccination, are they given a vaccination card? I think it's similar to the earlier question, Dennis, asking about the personal record of those that have been vaccinated. And then if so, how are you handling the cost of printing the cards? So maybe if you can respond to those questions, Dennis, they are in the chat area.
Okay.
Thank you.
Let me start. Thank you, Chair. Moderator, let me start with the first one, that are we prepared for the scaling up of the vaccine? As a country, yes, because at the moment people are struggling for us. People are moving about 100 kilometers looking for a COVID vaccine. So once we get another supply, automatically it will be consumed. Because now the demand for the first dose is higher than those who are getting the second dose. Because people at first were like that, and now I think they're getting the vaccine as we wanted. And we wish we had the vaccine even yesterday to give it to all those who are demanding it now. Because this to us, we're giving vaccine, it's not mandatory. It's just the will of person to get the vaccine is given. Otherwise, it's not a mandatory. Then for IIF, yes, we had a system in place. We are getting out the vaccination, the NIF organized due to the vaccine, and we are monitoring on a weekly basis. When we have APF, they present the figures, how many people have reported any sign and symptom of due to NIF condition which has occurred. So we have that system in place, and we have the form and the social committee are there, and even those people can do the causality analysis are there, they're ready, they're doing that for all those cases that have occurred due to COVID vaccine. Then our vaccination, at first, as I said, we started with the district going around development facilities, because at that time we didn't have enough funding. But later on, when we got funding, we trained all our health workers in the districts, and currently all health facilities are giving the vaccine. When there's a public or private institution, as long as they have our EPI refrigerators, they can keep our vaccine within the community temperature, they're able to work to vaccinate and get us a report once they have completed the vaccinations. So what I can say is we are giving, we don't select the facility, all the facilities are provide vaccine and we provide them for the COVID vaccine. Then the other one was on social mobilization to the rural community. Yes, we currently using even the community radios, which are in each and every district. And those community radios are able to disseminate the message in their own local languages. So that's another area which we have used to send the COVID vaccine messages through local radios or community radios, which are in the local languages. But also, we have also printed quite a number of posters, which we have sent to districts and that displaying the health facility and the facility that distributes the community. So that people should be able to get the messages on COVID vaccine. And after training our health workers, most of the time, health workers, we say they socially meet with the communities, they can talk to local leaders, even at an outreach clinic, even at our health facility, give messages or get a talk on COVID vaccine. So these are some of the combined strategies we have used to disseminate information into rural areas, so that people should be able to know the importance of vaccine at the moment. And we're seeing even the uptake increasing now in rural areas. I think these are some of the questions we had. Let me just see if there's any question again. Okay, so on the identification card, yes, we have the identification card. We printed them, and each person who is vaccinated, he gets a card. And we are supported by UNICEF, who gave at least, we printed about 2 million identification cards, which once we give when we vaccinate a client, we give a card. And we also had a register, which also we were supported by UNICEF. We print about, at first we put 1,000, then we also increase, we print another 5,000, and that's COVID vaccine registration cards. Even I think another party now also are supported with 500 registers. So in total, we had about 6,500 registers, which were distributed to facilities. Some are still at our office for distribution to the next consignment when we are going to get it. So we did that. We used to support with the printing of the ID cards and the 5 vaccination registers, and even the health facility reporting book. So we got support from UNICEF. Thank you. I think that's what these are some of the questions. There's a question which
Thank you so much for the comprehensive responses, Dennis. I think the colleagues are getting the information and they're getting their questions answered. There's just maybe another 3 more, Dennis, before we move to the next segment. So how do you manage the routine immunization and COVID vaccination? And then another lesson is the need to monitor COVID supplies. This is advice from a colleague. Sometimes it becomes difficult to use the vaccines which are about to expire when the country receives more supplies, which expire in just a few weeks or months. I think it's you did mention one of the vaccines that came and had a very short lifespan. So perhaps you might just want to comment again for emphasis, but this is more on the advice. Over to you, Dennis.
Thank you, Moderator. I think as a country, we didn't experience any problem managing the routine vaccinations with the COVID vaccine because we have integrated the COVID vaccine within the routine immunization. It's part and parcel of our activity. So the health workers, if they go to outreach, we say they can even carry a COVID vaccine, and those people who need this vaccine can get there. But even at a health facility, where they keep the vaccine, if some people come and need vaccine, they can be vaccinated because people are there. We have adequate staff as vaccinated. Most of the time, we have the HSA who are vaccinating the vaccines. So it was not a big deal managing the two vaccine within the program or routine activities. So that's been done. Then as somebody was on the expiry date, yes, it's quite difficult. We were put in a fix when we got the 102 doses for AU, and we noted that the expiry date is within the 2 weeks. So what we did was, at first, we were only targeting the health workers, the social workers, which were paid at women in uniform. Then also we had those people with ordinary conditions. Then we also had those who over 60 years. That was our target. But when we had this 100,000 doses from the AU from African Union, then we also changed our strategy. Instead of concentrating on this one, say, okay, can we open the vaccine to anybody who's above 18 years, so that at least we consume this vaccine as soon as possible. And we started our health, and we use this vaccine first before go to another vaccine which expire a bit late. So this is what we did. We planned as a country. We said, let's use the African Union vaccine first before we move to another which will expire at a later date. So that's how we manage this one, and we think with that better preparation planning, we're able to handle that. Although we discarded a few doses, about 90,000 doses from the African Union vaccine which we got because of the expiry date. Then, can you remind me the other one also?
Sorry, so the last question. So it was more on advice on the expiry. You did touch on it, Dennis. The last question that just came in is what strategies have you to address the public fear of serious adverse events? And they give an example of the vaccine-induced thrombocytopenia. How easy has been the procurement of drugs to manage these serious adverse events?
I can't comment much on that one because perhaps as a country we have not experienced that condition they're talking about. But we know some of the conditions have been managed at the district level and other even in central hospitals for those who are due to AIDS, due to COVID vaccine. But otherwise, I don't remember having reported any serious case which would also want to look for other additional measures. But we have the IF committee which is looking into that, but they have not put any case of that or serious nature.
So which is really the advantage or the joy of integrating with the routine immunization program, because then there's a firm program to manage adverse events as you have articulated earlier. And then for the COVID-19, it's really for the clinicians or the case management to also highlight high levels of high index of suspicion for some of those serious adverse events which are related to specific vaccines. So I think do we have any other questions, any other additions, Dennis, before we move to the next segment?
I don't think I've got anything, but I just had to go further on what we're saying, that when we are training our health workers, we had also module on how to report an IF and form to fill. Also, when we were doing the first vaccination of health workers, we had formed a team which comprises even a clinician or there, an SC or there, a vaccinator or there, HMS officer, and even a coordinator or there as a team of 6 people. And we advise them that once they have vaccinated a patient or a client should wait at the vaccination site for almost 15 minutes, waiting for any side effect that can occur at that time, then the clinician will be able to manage. So those are our next which we create to our health workers during the trainings. I think that's what I can say, Abraham.
Okay, I think that quite clarifies, and I hope the colleague is satisfied. I was just asking our secretariat in terms of our time. And also to any other additions, comments, questions before we move to wrap up.
We've got a good 5 minutes or so.
Okay, great. So we are exactly on the wrap up and recap. And I once again just want to thank my colleague so much, Dennis. It's really been a very rich information sharing platform. And he gave us all the information from where they started in Malawi with the first case of COVID-19 having been confirmed in April, and then quickly moving as the vaccines were being rolled out to see which ones the country could afford in terms of their affordability financially, but also the logistical arrangements, given the complexity of COVID-19 vaccines, the cold chain capacity. So they were then able to access 3 vaccines so far, but they are also in the process of getting more. They have put in place the systems to monitor the coverage of the vaccines, but also to ensure the synchronization of data in terms of the paper-based and the electronic system. They've gone through what a lot of us have gone through, the misconceptions, misinformation, but they've come up with strategies to ensure that that is corrected countrywide, rural and urban. So there's been quite a lot of strategizing and re-strategizing, including even addressing the knowledge gap and ensuring that all health workers are well informed so that they address the competing priorities that they saw earlier on. They've addressed their partners and they're looking into additional funding to ensure that the vaccination program continues as they respond to the pandemic in Malawi. They've integrated COVID-19 vaccination within the EPI program in terms of both the health facility and so they mentioned this facilities. This was also in terms of micro planning, ensuring that people know who is doing what where. But also a special mention was made of the political will, where the president and vice president actually showed up for vaccination and therefore dealt with a lot of the myths and misconceptions and some of the fears around COVID-19 vaccination. So ladies and gentlemen, there we are. I think it's really been a very good webinar. And I also want to acknowledge and appreciate Secretariat past BLN. Over to you, Secretariat.
Thank you very much, Dr. Manangazire. I totally agree with you. It was a very engaging and very insightful discussion. And thank you very much for driving it well. To the audience, we've come to the end of the webinar. I would like to thank you so much for joining us today in this engaging discussion. I'd like to again thank the moderator, Dr. Manangazire, for not only leading the discussion, but also drawing out the key lessons that we learned today as she ably summarized it. And a very special gratitude to Dennis for sharing and elaborating on Malawi's experience with the vaccine introduction. And just to let everybody know that this webinar, like I mentioned earlier, has been recorded, and we'll be sharing it through our normal BLN channels. And I would just like to encourage you to continue connecting with us on those different platforms that you're seeing on your screen. We've got a website, we normally have blogs, and we have a Google group, and we also have social media platforms where we share information. So we're also encouraging you to subscribe to our newsletter. And would like to thank you most sincerely for joining us in the last 3 months, where we've been discussing, and we learned lessons from Cameroon, we also learned lessons from Liberia, and today we heard from Malawi. And just to let you know that in the next series, we'll be looking at how the other sectors are dealing with this. For instance, I think Dr. Manangazire raised a very good point earlier when she was talking about stakeholders and also the private sector, how the public health facilities dealing with the vaccine rollouts, since most of them are supporting the various governments in deploying the vaccine. Well, until then, we say thank you very much, and also keep safe from COVID-19. Let's not forget to observe social distancing, masking up, and washing and sanitizing our hands frequently. And also just to encourage us to get vaccinated against the COVID-19. We haven't done so yet. And so until next time, thank you very much. Bye.
Thank you, Catherine. Bye.
Thank you very much.
Thank you and goodbye.
Thank you.
Thank you,
so much.
Achimwene.
Thank you.
It was a very lovely discussion. Bye.
Bye.
Thank you all.
Hello. So the Secretariat is having a bit of a challenge, a technical challenge. So she's just trying to set up, but just a warm welcome to everybody. So we're just holding on to the Secretariat. Kindly be patient with us. Thank you.
Can everybody hear me?
Yes, please go ahead.
Okay. Sorry. Technology today, I think my connectivity is very bad today. As I was saying, a very warm welcome to everyone. Hello.
We're here. We can hear you.
Okay. Yeah. Let me quickly, because I think now we're running out of time. I'd like to welcome everyone.
500,000 people this year. How can that be? I wonder if the board sits and considers that to be morally acceptable.
A warm welcome to everyone. Can you hear me? I'm getting some feedback.
Yes, we can hear you.
Are you able to hear me? Oh, okay, okay. Yes, as I was saying, my sincere apologies, but a warm welcome to everyone to this webinar where we'll be looking at the introduction of the COVID-19 vaccine with lessons from Malawi. This has been the third in the series where we heard from other countries. My name is Catherine Muyawala, and I'm the Learning Network Coordinator. And we're having these webinars so that we can all learn from one another. So for most of us, we know that, well, I definitely won't even go into the normal nitty-gritties of the webinar housekeeping. Just a quick one, just to ask everybody to make sure that they're muted and that the videos are disabled, and so that we can allow the discussants to speak without interruption. I just let everyone know that there'll be a question and answer session after the discussion. And we're going to ask you to submit any burning questions into the chat box, and they'll be logged and answered during the question and answer session. And of course, just to let you know that this webinar will be recorded, and that the link to the recording will be shared via our Google groups and also through the BLN website. So, as I have already said, we know that the COVID has really affected us in so many ways, and and we know that currently we have over 180 million cases. That's according to WHO, and we've had close to 4 million deaths. This is around the world. And then in Africa, we know that our cases are above 5.3 million, and we've experienced quite some devastating numbers in terms of death. And we're very grateful to WHO, UNICEF, Gavi, the Vaccine Alliance, and all the other partners that have worked diligently to ensure that the world receives this much needed vaccine. Receives the much needed vaccine. And so in that case, would like to learn more from the countries that have been deploying the vaccine. We know that currently about 2.4 billion vaccines have actually been deployed globally. And in Africa, we've got a number of countries that are more than 47 that have benefited from the COVAX facility. And that's why we're having these learning webinars, so that we can, because we're all on the learning curve, and I'd like to believe that everybody wants to learn. And we've had other countries come on board. In the last two webinars, we heard from Cameroon, and we also heard from Liberia how they've been doing with the COVID vaccine deployment. So today we'll get to hear from Malawi, and we're very happy that we have in our midst Mr. Mangumba, Mr. Mangumba from Malawi, who's going to speak to us about that. Sorry. And just to lead us through the discussions for today, sorry, we have Dr. Kosha Manangazira, who happens to be the BLN peer advisor from Zimbabwe, and she is a public health expert who has worked as a lead epidemiologist for the Ministry of Health and Childcare in Zimbabwe. And for the last 15 years, she spent about an extensive experience in the coordination and management of communicable and non-communicable diseases, prevention and control programs. and her responsibilities and experience span the control of communicable and non-communicable diseases, health promotion, implementation, science, and health information. She is responsible for planning, coordination, and management of public health programs, as well as the development and implementation, monitoring, and evaluation of health information, disease prevention, and control, including emergency preparedness and response. Looking at policy strategies for national and regional levels, and during her distinguished career, she also received international recognition. Dr. Manangazira has introduced several national programs and made significant contributions to science through research and has published numerous articles. Additionally, she has led and coordinated various national population-based communicable disease surveys, notably the Zimbabwe Demographic and Health Survey for the years 2005 to 2006, and also for 2010 to 2011, as well as 2016, and has also